We are here to honor the legacy of a great preventive medicine leader, Dr. Daniel S. Blumenthal, and you're in for a real treat. You really are. I'm Donna Grande. I'm the CEO of the American College of Preventive Medicine, and it's just an absolute delight to have you all here today and to celebrate with us the remarkable advances that we've made, yet we still have a long way to go. I will say that change takes time, and with persistence and tenacity, we will arrive at a day and a time and a place in our country where all people around the world have the chance for optimal health. I'm going to introduce Dr. Crosswood to get us started, former board president of the American Board of Preventive Medicine, fellow of the American College of Preventive Medicine, and current president of ACPM. Dr. Crosswood.
Thank you, Donna, for a very kind introduction and a very warm welcome to everyone. You know, in preparing comments for today and thinking about this event and reflecting more or less on Dr. Blumenthal, as I called him. I met him as a resident in Deep South. We call him Dr. Blumenthal. Thinking about his work, came across a quote from Albert Einstein. And the quote was, "Strive not to be of success, but to be of value." In May of 2017, Dr. Daniel S. Blumenthal was the president of the American College of Preventive Medicine. He also had a very important responsibility as he presided over the annual Preventive Medicine Conference, where he selected plenary and keynote speakers and essentially defined the theme for the conference based on his experience and programmatic expertise looking at social determinants of health. And the theme that he and his team chose was a focus solely on disparities in health and healthcare. Now, this topic was being thrown around in the medical world at the time, but he was truly ahead of his time in focusing an entire conference on this issue. In 2019, Dan died suddenly. It was before the COVID-19 pandemic, before the social unrest that burst out nationally after the death of George Floyd, and before we began a sincere and focused effort looking at social determinants, social justice, and the impact this had on health. You know that Dan would have wanted to be a part of the discussions. He would have wanted to be mostly part of the solution. Dr. Marjorie Spears, the wife of Dr. Blumenthal, served as the Deputy Associate Director for Science at the Centers for Disease Control and Prevention, the Executive Director of the National Bioethics Advisory Commission, President and CEO of the Association for the Accreditation of Human Research Protection Programs, and the Executive Director of Clinical Research Pathways. No surprise that she and Dan were completely aligned in their passion for science, for representation, and social justice. As his wife, as his soulmate, please welcome Dr. Marjorie Spears to share a few insights.
Well, hello. It's good to be here again. Another year has passed, and I'm very pleased to be part of the annual award and lecture in honor of my husband. What I have been asked since the beginning of COVID in January of 2020 till now is, well, what do you think Dan would have thought about it? Well, I don't really know, okay, right? You can't ask the dead what they think about things. But as you heard, we did share a lot in common. We talked a lot at home about health, public health. The effect that COVID-19 had on minority populations was extreme and extensive. But, you know, among Blacks and Hispanics, Latinos, more death, higher death rate, more hospitalizations, more severe disease. Since the time of our meeting last year, in 2020, we have seen other negative effects of COVID-19, how it affected essential workers, who are often minorities, how it affected school children, kids who couldn't go to school, private schools opened, public schools did not. Some kids did not have access to laptops and couldn't really zoom into classes, or they had no one at home to watch over them to make sure that they were doing their homework and paying attention. The last thing that I want to mention about Dan is that there was a book that was published, that was actually published in May of this year. The book is called The Morehouse Model, How One School of Medicine Revolutionized Community Engagement and Health Equity. He was working on those chapters the day of his death. So he continues to be with us.
We miss Dan, we know that you do as well, and we're grateful for the legacy that he has left us. Your comments, though, are an absolute perfect segue into our featured presentation today and announcing our second annual Dr. Daniel S. Blumenthal Lectureship in Health Equity and Social Justice Award, and to introduce today's keynote speaker and awardee, Professor Daniel E Dawes, Juris Doctor.
Hello, everyone. I am so honored and humbled to be receiving this amazing opportunity of speaking before a room full of not only greatness, but before the women and men whose work, whose lessons learned, whose mentorship and whose missions have and continue to inspire me. An ounce of prevention is worth more than a pound of cure. You see, even before he hit our campus at Morehouse, Dr. Blumenthal recognized that healthcare professionals held an enormous amount of potential to positively affect social change through their experiences working as a physician in a broken healthcare system. In fact, Dr. Blumenthal devoted almost 40 years of his life training a wide range of rising and current health and healthcare professionals about how to respectfully and properly care for and treat our nation's most under-resourced and disadvantaged population. He sat in a position upstream and could foresee that without major systemic changes, there would be negative health consequences that would befall Black, low-income, and other minoritized individuals and communities later on. One quote in particular always comes to mind for me. "The chains of habit are too light to be felt until they are too heavy to be broken." That the only way to truly accomplish lasting and meaningful change is through a commitment to moving outside of the status quo. I know that we all know the long arc of history eventually bends towards justice. But as it bends, it can also wobble. Research is showing how little progress we are making in eliminating health inequities in America. Within healthcare and public health, we are awakening to the ways in which research has falsely looked at race as a biological attribute rather than a social construct over centuries, contributing to systems of racism in healthcare delivery, education, housing, transportation, employment, and public health. And at long last, medical, nursing, and public health science are declaring that race is not biological, but that racism has profound consequences for health. 10 years after Dr. King died, Dr. Martin Luther King Jr., the United States government finally held its first ever congressional briefing, or rather hearing, to specifically address minority health and health disparities in the country. Although a full commitment to equality has never characterized American health policy, serious questions arise whether the present partial commitments to equality in healthcare will be maintained. What's even more concerning to me is that health equity leaders back in 1979 doubted that even the limited gains they had achieved would be maintained into the future. Unfortunately, they were right. We can no longer afford to embrace a partial commitment to equality in healthcare. Now, I know that progress has been made in the fight to reduce racial and ethnic health inequities and expand the conversation about their root causes. Today, The social determinants of health are widely recognized as contributing and even determining as much and even more to the health and well-being of individuals than medical care has. But it's also clear that we still have so much more to do and so much further to go to address the fundamental causes and the instigators of health inequities in the United States and around the world. What can we do as a community of health equity champions to mitigate and eliminate their negative impacts? The answer is clear, very clear. We have to look further upstream and focus on the political determinants of health that provide the momentum and currents that have created and sustained the social determinants of health. We must ensure that we keep structural racism at the forefront of our research, of our analyses and practice, so that the impact of explicit and implicit racial bias does not get watered down. In the wake of this COVID-19 pandemic, we've seen a repeat of a historical tragedy during a modern era, which we've come to believe is more evolved and learned from any previous point or time in our history. When does it end? When do we finally allow history to remain history and stop it from continuing to repeat itself? Policies reflect the current values of their time. As we move into the future, it's worth remembering that the movement to advance health equity is not for the faint of heart. I am so hopeful about our future because I know we have such leaders and champions represented at the American College of Preventive Medicine. Thank you all so much again for this honor.
You know, we talk about and we sometimes may forget, but we as physicians can affect social change. Maybe it takes a lawyer to remind us about that sometimes. I'll now introduce the moderator for the session, Dr. Reed Tucson. He's Managing Director of Tucson Health Connections, a recognized leader in his field. Dr. Tucson has been appointed to leadership roles at the National Institute of Health, National Academy of Medicine, numerous federal advisory committees, and since he's come up in a hurry, I won't go through the rest of it.
Well, I'll get started. I think they'll get the hum out of the system some kind of way. And I had the great privilege of receiving that lovely award from Dr. Spears, and it's still a wonderful treasure for me. So great to be in your company again. This is a transitional moment in our industry. It's a transitional moment in health and medical care. And we'll have to make sure that we take good advantage of it. The issues of inequity, distrust, misinformation, social determinants of disease, all of them form together into this brew that leads us to death and misery. We've got to overcome fundamental key contextual forces. And I think Dan Dawes really got a good job of that. But let's just realize what we're up against with this tribalism, this toxic sense of me against thee. And the tribes are getting smaller and smaller. Anything that is other than you is a problem. And power is being exerted across all of those different domains. And Dr. Julie Morita, if you would, in fact, first, Julie, be right here and ready to go, because as we just heard, you may not know this, but you are a physician who is the Executive Vice President of the Robert Wood Johnson Foundation, where you oversee all program, policy, research, and communication activities. For 20 years before doing this, when you were very young, you were in the leadership in the Chicago Department of Public Health. And while commissioner, led the development and implementation of Healthy Chicago 2.0, a 4-year health improvement plan focused on achieving health equity. Thoughts on the topic?
So maybe what I will do is, well, first of all, I want to stop and to thank the ACPM for inviting me to be here today, to really be able to be part of this celebration for Dr. Blumenthal, is to talk a little bit about what Robert Wood Johnson Foundation actually does, because some of you may not be familiar with it. But the foundation is actually the largest national philanthropy that has focused solely on health and health equity. And we've been doing this for 50 years. And for the first 40 years we were working, we really focused on health and healthcare delivery. But what's happened over the past 10 years or so, since 2014, we actually launched a vision of a culture of health. In 2014, when we launched our vision of a culture of health, health equity was always a real focus and central to our vision. What's happened over the past couple of years, the foundation has increasingly focused on structural racism as a barrier to health, recognizing that while we're focusing on systemic and structural barriers to health overall, there's no greater barrier than structural racism itself. And so we have become much more explicit and intentional in that focus in our work overall. The foundation is really doubling down on this commitment to the communities who are most affected and really focusing explicitly on structural racism as a barrier to health. So we make grants. We distribute about $650 million a year to support improving health overall within the nation. We fund research, really exploring what the connection is between structural racism and health overall. We also are looking at challenging conventional methods of research and assumptions.
Let me ask you one quick question, which is an impossible question to answer. If we're going to start to take what Daniel said and what you've said in terms of the politics of this, how far into that set of weeds are we planning or willing to go? Are we talking about vetting candidates? Are we talking about giving position papers to candidates? And also, are we talking about trying to foster conversations with people who think differently than we do? Is this going to be where we arm our side to beat up on their side, or are we trying to change the political equation? As I said, it's an impossible question.
Yeah, thank you so much for that very easy question. There's so much that I could actually say about that, because I think one of the things that we've really focused on over the past few years is really learning about the community power. I mean, I think we've talked a lot about community engagement and community voice and lifting it all up, but it's really not a matter of just engaging with community. It's really helping community to have the power to raise their voices, to talk about their conditions, to talk about the challenges they have, and also to enable them, empower them to be able to actually lead the solution development. It's not just about engaging with community to tell them how they should fix things. It's really about bringing community into the solution development themselves. The other thing, though, I have to say is that for decades, the foundation had said we're nonpartisan, that we were going to walk this line so that we can engage with both sides of the aisle and really be able to advocate for policies that appeal to all. And we do believe that that is really important, that we can't do this alone. We can't just be entirely working with the left on some of the issues that we find really, really important. So how is it that we get to the point where we can really address shared values, which I think are really there on both sides of the aisles, is really engaging with both sides of the aisle at the value level, because I think there is commonality. And so we're really striving to see how it is that we can lift up these policies, which are pretty left-leaning. Our policies that we support are really, really left-leaning. How is it that we engage with the other side of the aisle to help them to really understand what we're talking about and helping them to understand that we can really move together and we will be a better place, a better country overall if we really work together?
George Rust, you may not realize this, but you are usually found as a professor at the Florida State University College of Medicine in Tallahassee. I hope everything is okay.
Absolutely.
Where you direct also the Center for Medicine and Public Health. You serve as medical executive director for the Leon County Health Department and 5 surrounding rural county public health departments. Thank God for you. Thank God for you. Board certified in both family practice and preventive medicine. You've taught for 24 years on the faculty at the Morehouse School of Medicine, where you were founding director of the National Center for Primary Care. And in 2017, Dr. Dan Blumenthal presented you with the ACPM President's Award for your contributions on health equity. Congratulations on that.
Thank you.
What are your thoughts, sir?
Well, first, let me just say it was an honor to know Dan personally, and I would just echo all the things that have been said about him, the gentleness and kindness. I appreciated that comment. The one I would add to that is humility. Let me offer 3 thoughts, if I can, real quickly. One is that we got to believe. And what I mean by that is we have to have an affirmative expectation that health equity is the only acceptable outcome and that we're going to get there. You look at some of our great leaders in history. I think about Desmond Tutu saying that we have already won 20 years before apartheid ended, and speaking it into being. Disparities are not inevitable. Equity is achievable. The second thing is, aside from we got to believe, I'd say we got to work together. And part of that is across racial ethnic groups, that glorious rainbow coalition across gender marginalized communities, finding those commonalities to work together toward equity as that positive outcome. But working together in other ways in which we tend to say this, not that. Prevention, not cure. Upstream, not downstream. And the third thing I guess I'd say, and this is relevant to Dan's career, Dan Blumenthal's career as well, is that some of you are probably too polite to have noticed, but I'm a white guy.
Oh, really?
Truth be told, I'm a cisgender, not very good Christian white male. And my message to my people would be, get in the game. I grew up in a semi-dysfunctional family, and so I understand about walking on eggshells, of trying not to deal with the elephant in the room, of abuse or of dysfunction or of anger or rage. We can't afford to do that. This is not somebody else's problem. This is not for minoritized communities to fight this battle by themselves. And so whatever power or privilege we have, we've got to use that. There are some organizations that are so white and so male in their norms and their culture and their power that nobody but us is going to be able to advocate for equity. There are other organizations that are more diverse where we can amplify voices of people who do have authentic lived experience and whose voices need to be heard. And sometimes I just need to say, we ought to listen to them. They make sense. They're right. And amplify those voices.
Well, this is, we joked about this point about you being a white male, but this is very serious because I think that the more I look at how I react being on too many town hall presentations and so forth with well-meaning brothers and sisters who are white, is to say, look, black folks are tired of trying to explain to you what this is like. And by the way, black folks can't convince white people to stop being racist. That's going to have to come from y'all's family. And I wonder whether you think that there are places, inroads, for well-meaning people who are white, who have common shared human values, to have those conversations with their friends who may actually identify as being Republican or libertarian or whatever. Is this possible?
The analogy I would give is that as a primary care physician, I've always considered it an honor when I'm working with a patient and we have to discover together the diagnosis of cancer. And it may be my role then to facilitate a conversation between that patient and their family where they all knew what was going on but were afraid to talk about it. And they each say the word cancer out loud in front of each other. Some institutions that are historically white and have persisted in their historical whiteness have a hard time saying the word racism. Why is it that we claim to be a diverse organization, but the diversity is all on the front desk and among the nurses' aides, but the farther up the chain I go, I get to white women, and then when I go to the C-suite, it's white men, or the governing board. And so being able to, a phrase that I routinely use in that context is vertically proportionate diversity. And encouraging organizations to audit themselves on that. How are you doing across all the levels of power of controlling budgets and hiring and making policy decisions? How are you doing on making sure that the people, the communities that we serve, that we are just as diverse as them? Where are the trans voices in our organization? How do we make sure that we're getting authentic representation of those voices at the power levels where they'll really be heard and make the difference?
That is a very sophisticated point. Thank you for making it. Well, Jesse Ehrenfeld, you don't know it, but you're the president-elect of the AMA, my friend. Congratulations.
Thank you.
But when you're not doing that, you're somehow passing gas, doing anesthesiology, you're doing a clinical practice, you're doing research, you're doing health policy, you're teaching at Vanderbilt, and then somehow you're directing a $650 million statewide health philanthropy. So, good on you, brother. You, a combat veteran, deployed to Afghanistan, but for 20 years you have advocated on behalf of the lesbian, gay, bisexual, transgender, and queer community. Thank you for doing that. And you and your husband have a son named Ethan, excuse me. And as you look at all these multiplicity of your roles, how do you focus in on this issue of equity?
You got it right. I'm president-elect of the AMA. That's a new role for me at the AMA. But what I'm not new to is trying to do the hard work of achieving optimal health for all. I am an anesthesiologist, and yesterday morning, I got up at 5:45, got dressed. My son Ethan got up a little bit later, got him going. And I got to the hospital. I walked in to see my first patient, and she was a 72-year-old black woman who has newly diagnosed advanced breast cancer. It has spread to her lungs. She is likely going to have a tragic, preventable outcome, not because of anything that she did wrong, but because our healthcare system has failed her. And to advance the goals of health equity, the AMA has doubled down. And we have said we have to have an aggressive effort to eliminate long-standing equities within our healthcare system caused by structural racism, to remove those barriers to care, and to improve outcomes for historically marginalized communities. In 2019, we took a really important step to create our new Center for Health Equity that really is a hub for our equity work. And I know that Dr. Aletha Maybank, who is the leader of that hub, was with you all last year when this award was inaugurated. We recently launched a medical justice and advocacy fellowship in partnership with the Morehouse School of Medicine that we're incredibly proud of. And in 2021, we publicly acknowledged in our plan to embed racial justice and advance health equity, which is a multi-year plan, where we went wrong. And to acknowledge those missteps, to acknowledge the opportunities that were lost, and to chart a pathway to the future is really where the center and the leadership and hopefully my presidency will be able to drive towards. And when I think about what's in that strategy and that plan, a core component is to push upstream to address all of the determinants of health and the root causes. And for almost a decade, I led an LGBT health program at a major academic center, a program which last week, like about a dozen other programs around the country, came under vicious attack. Public threats of violence on national television. When I think about how do we erase barriers to care in the LGBTQ community, we've got to push upstream, like our keynote awardee talked about tonight, to look at the larger legal and political climate. It's the only way we're going to get there, and it is challenging, particularly when we look at what we're up against. But we know that if we don't undertake that, the challenges that trace all the way back to childhood, to school, the home, that lead to these preventable outcomes will continue. Suicide is now the second leading cause of death for all people 10 to 14. The Trevor Project, which is a wonderful resource, they're a crisis intervention advocacy group. 45% of LGBT kids in America, that's 1 in 2, considered suicide last year. And there's a lot that's driving that. And the Trevor Project, which 24/7, 365 days a year, they are available online, on the phone to support youth. They were called out by an online harassment campaign that was solely designed to flood their online channels to prevent kids from having access to services, with a very deliberate attempt to harm these children. We've seen death threats to people in my immediate community who are trying to provide appropriate evidence-based care, and these attacks are disheartening. And the fringe elements in society who now feel empowered by the political current, the climate, they win. When we allow this intimidation and violence to be unchecked, when we allow misinformation, disinformation to be spread, and that's a lot for anybody to take on. Collectively, we have to redouble our efforts to make sure that we chart a future that pushes upstream, as Mr. Dawes encourages all of us to do, and I am so happy to be here to help try to think through what that can be for all of us collectively to do.
How is it that you, sir, with your concern for equity and the things that you stand for are now the president of the AMA. Is there something here that starts to signal a sea change in the way organized medicine and the physicians that would traditionally find their way to the AMA are starting to view their profession?
I think there is. I am a little bit different than my predecessors, and it's not just my hair, my great skin tone. I moisturize every day. I know there's a dermatologist sitting in the audience. But I wear this pink tie with pride as the first LGBT person on the AMA board, and now as president-elect, as a very young AMA president. When I look at who makes up the physician community, it's still not representative of our nation. We are making strides, and I think I've seen that in the 20 years that I've been involved in the AMA. I still remember pushing for a committee to work on LGBT health equity issues 20 years ago, 15 years ago, and being pulled aside by a mentor and said, Ehrenfeld, I'm not sure that's a good idea. There may not be a place for you at the table if you do that. And I said, it's the right thing to do. And here we are. So I remain hope. I know that we have a lot to do. I know that the pipeline is not there, that the pathways are not open, but we're going to change that. And I'm certainly committed to doing that from where I sit.
Well, Sarah DeGia, you've had a lot of time to realize that you are, in fact, the CEO of Change Lab Solutions, that you apply your legal expertise and leadership experience to advancing equitable laws and policies that ensure healthy lives for all. I'm really pleased when I read about Change Lab Solutions that you've established new partnerships to uplift health-promoting policies in rural America, assist community efforts to increase affordable housing, strengthen resiliency and the opportunities for children and families, supporting public health agencies and equitable enforcement, and expanding innovations in equitable and sustainable food systems. You sit on the Advisory Committee for the Office of Health Equity at the California Department of Public Health, the Advisory Council of the Healthiest Cities and Counties Challenge, and the Editorial Committee of Public Health Watch, among many other affiliations. You've heard a lot of this conversation. What are your thoughts?
So in my work at Change Lab Solutions, we're a national nonprofit organization, and we use the tools of law and policy to try to advance health equity. And what that means is that we partner with communities across the nation to really improve health and opportunity through all of the areas that you talked about by changing harmful laws, policies, and systems. Perspectives that I really want to touch upon are these around structural inequities. What does this mean? And kind of start to pull that apart a little bit. And I want to first do that by talking about the definition of health. It's not just the absence of illness or infirmity, but it's the complete physical, mental, social, and cultural well-being. There's no way that we can treat our way out of health inequities. We have to operate, invest, focus, and design our systems far differently, and in particular with equity in mind and at the center. So Change Lab Solutions has put forth a framework as well to think about structural inequities. And we call them the 5 drivers of health inequity. And so what we've done is try to draw on these different disciplines to, again, put forth some tools for change. Because we know that while laws and policies have been used to create and reinforce racism, they are just as powerful tools to be able to create change. So the last thing I'll say is that laws and policies alone cannot affect change. You have to couple law and policy with the communities who need it the most.
What's it going to take, you've been studying this, Julie, for us to regain the public health trust of the American people?
There's no way for governmental public health or for public health as a sector and as a whole to regain the trust unless there's adequate resources and funding made available to support public health. You think about it, it's interesting because NPR and Harvard did a poll, we supported a poll that they did, and what they found was that the general public, more than 70% of the public actually believes that public health needs more resources. And they're also, 70% of the public actually feels like public health work is really important. And yet there's a lot less trust in public health than there is in healthcare providers, primary healthcare providers, or healthcare providers in general. And I saw this play out when I was in the city of Chicago. There'd be an emergency, a public health emergency, the pandemic, H1N1 many years ago, Ebola, big surges in funding, and then the funding would drop off. And then we'd have to scramble with the next emergency, and then there'd be another surge of funding. And that's what we're seeing play out right now, is this enormous surge of funding that's made available for 3 to 5 years, and the public health agencies have to spend the money, and then there's a cliff.
Outcome. So I'm a big fan, actually, of what you were talking about, which is micro, data at the most granular level you can get geographically, temporally, racial, ethnically, with rapid cycle feedback loops, and then democratize that data so everybody can see it.
By the way, you mentioned disparities earlier, and I just want to, closing gaps, I want to make sure everybody does realize that when it comes to primary series COVID vaccines, the black community, although they ran a race with an anvil on their back and old combat boots, tied Leave It to Beaver with the newest jogging suit. We did close the disparities gap on primary series, and that's proof of what is possible, and that's why you got to believe. But let's stay in this bi-directional river. When I was privileged to be to run the medicine portfolio of the AMA, which still shocks me that I had that opportunity to do that, they were buying up a lot of land in Chicago, all around their building. They just owned all this land. You, sir, are part of an AMA that is investing in the community of Chicago, but it's not land. What are you doing?
So we know that if you look at any metropolitan area, there is a significant gap between life expectancy in the wealthy neighborhoods and in the poorest neighborhoods. And so on the west side of Chicago, in the AMA's headquarters in Chicago, a person lives 17 years less than somebody in Chicago's wealthy neighborhoods. And so 2 years ago, the AMA decided that since Chicago is our hometown and has been for 175 years, that it was time to invest and do some place-based investment with community partners. And so we invested $2 million in Westside United, which is a really impressive collaboration of civic leaders, residents, healthcare players, community groups, faith-based organizations, to come together to restore the economic vitality, educational opportunities, generate local investment, try to create corridor redevelopment, affordable housing, capital improvements, things that we know lead to healthier lives, to start to chip away at that 17-year gap. And so we're going to do some follow-up investment on that work, so to be announced soon. And if we're successful, we hope that this can be a model and an example of how we can start to improve outcomes, narrow that life expectancy gap in similar communities across the nation.
Beautiful. But can you give us a couple of examples or one, at least maybe one example of something that worked well, where we actually saw the legal and the health come together?
Yeah, so we've been working with healthcare institutions for a long time because, again, we believe they're really important partners. And oftentimes what we find is that there's perceived legal barriers or policy barriers that are kind of lifted up as like, we can't do that because that's against the law. And so part of what we use our tools for law to do is to actually help people dispel and really understand what are the laws and policies and how you can work with them in order to make change. And we're also seeing healthcare sector partner with housing partners as well. Not all healthcare sectors can invest in housing themselves, but they can be a part of the process. So we've seen in Denver, for example, and many other places where healthcare partners are actually at the table, helping to facilitate community engagement, helping to bring community residents to the table so that they can listen and invest their dollars in a way that's actually going to make a change. So those are just a few examples. There's many more, but I think it's just the tip of the iceberg of what more we can do to use that role as influencer from the healthcare sector, which has tremendous influence and resources and data to be able to make even greater change.
So I'm going to take advantage of this opportunity to push back on something you said.
It's gotta go. See you.
Oh, no. Sit down. So what you said was that the disparity in vaccine coverage levels that we saw be eliminated with COVID was because we believed. And I think believing is really, really important. But it didn't, that disparity did not diminish and was not eliminated because we believed.
That's right.
It's because there was a commitment from this administration to look at the vaccine distribution program and make sure that it was equitable. And it meant dollars were put into the community by way of public health, by way of the healthcare sector, by the way of nonprofit organizations to mobilize community, to promote and demonstrate and advocate for vaccination within the communities. And so it was not because we believed, but because there were adequate resources that were put in place to make and to create the systems that really allowed people to be vaccinated. Unless we continue to sustain the resources for public health in an ongoing way, we are not going to sustain that commitment to health equity.
We are saying to the CDC, as loudly as we can say, to HHS and their other agencies, as loudly as we can say to them, stop giving us this piecemeal money that comes through some gigantic white organization that's the bundler, and we walk around like a character in Oliver, please sir, can I have some more? No, we want to be at the table, we want to be steady funding, and we've called for, right now, at least initially, a $100 million fund that will be able to create some basis for infrastructure and then build it over millions over the future. So I completely applaud you on that point. It takes belief, but it takes a lot more than that. Good.
I think we've got to get the money and the power right. And starting with making sure that the power and the money are in the hands of the people whose problems we say we're trying to solve. I see in the university setting, so many of us getting $10 million, $100 million grants and trying to work on community engagement because we haven't been so good in that area before. And my response to that is, what if you gave the $10 million or the $100 million to the community and let them decide how useful the university is in that equation? Now you'd have a conversation, right? And I think across all of these power dynamics and all of these money dynamics, we are working in a non-white world. That's always been true globally. It is increasingly true in America, that we are a non-white world, but we have historically white institutions that have grabbed up the money and power.
That's it.
And until our institutions learn to be truly non-white institutions, which means money and power in non-white hands, frankly, to serve a non-white world, a diverse world, then, and that goes across all the other domains of diversities, then we're not going to get it right. We're just playing at the edges.
And I would say that unfortunately the answer has actually not been yes. Something that is always top of mind for me is when we partner with an organization, a community group, an entity, a religious outfit, do we take from them or do we give to them and leave them better than they were when we found them? I would just encourage all of us as we think about how do we change that power dynamic to keep that top of mind so that we leave all of our organizations, all of our communities, all of our partners better than we found them.
Engaging community is good for health and it's good for public policy. Create an equitable process and really compensate folks as experts in their own field as you're bringing them to the table, and build capacity bi-directional, understanding the roots of the problems. We can't just start with today. We have to go back and look at the historical harms that our institutions have done to communities and how do we build back from those? And then we can move forward to figure out how do we align our resources in a way that we're building that shared partnership and that power sharing.
So the American College of Preventive Medicine is fully committed to this charge, to these calls to action, to live on the legacy that Dr. Dan Blumenthal began for us ahead of the time, ahead of the trend. We embrace the challenge. We look forward to the opportunities and to engage each and every one of you in our quest to make a difference in our nation, in our communities, and in our own backyards.